So Dr. Clemens, you want to get started? Here's the word on class. We like for you guys to be here because it's the discussion that's helpful, and there's no replacement for like working out everything and then getting feedback on what you did. But we do understand if there's weather issues or something like that and you can't stay for the full class time, then we're going to leave that up to you. But we are taking roll because we do see that there are several students missing. So if there are some students that couldn't make it for whatever reason, they can email me separately with their documented reason. So, all right. So Dr. Clemens, if you want to get started, I'll kind of be in the periphery for a little bit to see if I can make sure things go as smoothly as possible.
Okay, I'm going to try this desk mic, and Agnes, if at any point you really can't hear me, I can switch back to the other and see if that makes a difference. I will try to be very clear, but let me know if you're having trouble. I will do the best we can. We are going to jump in and start talking about Mr. Kinsdole. And so we are a little bit behind, so in the interest of time, I'm just going to give you guys like 2 minutes as your groups to really kind of come together, make sure you know what your primary drug-related problem is, as well as like the explanation for it, and then I'm just going to start with a volunteer to start with that. So give yourselves like 2 minutes, kind of get your ducks in a row, and then we're going to jump right in. This is Dr. Cummins. Last time, so I just like my check and changes were made. Is that better? Yeah, I can move again. I think so. I didn't look at it. Okay, so for the interest of time, I know it can get very long, but we're going to go ahead and come back together. Hopefully the primary problem in the patient was pretty intuitive. So if I can get a volunteer group to kind of tell us what is the primary problem and why you selected that. So kind of think about, always want to start with why the patient, what is their chief complaint, why did they come to the hospital, what is their primary problem?
We saw our primary problem was induction therapy for AML.
Good. So the acute myeloid leukemia is definitely this patient's #1 problem. As we dive into it, I will say that there's 2 different ways to approach this because AML then has some sub-problems within it. You can either present them all as sub-problems or as separate problems. In practice, it probably doesn't really make a difference, but you're going to have several things that you're going to comment on in interventions that could all be under AML as a sub-problem, or you could talk about AML and then all of these sub-problems separately. I personally don't think it makes any difference as long as you get them all. But I just wanted to point that out because within this, you have problems that are technically sub-problems, but some people will make them separate. That's totally fine. So the reason the patient came and their chief complaint is all related to their acute myeloid leukemia, so that's definitely the #1 problem. So if a group in Augusta wants to kind of tell us about this drug-related problem, let us know what the goal is for the patient, and then give us a statement about the plan.
So his goal is complete response or remission with less than 5% blasts in his marrow and no peripheral blasts, and then we might do the residual disease measurement, so we want to have measurable residual disease. He also certainly needs some CINV prophylaxis, which he has. We put under that like his tumor lysis, so that's part of it. The induction therapy was appropriate. He would need cytoreduction, which he got, and so now we need the hydroxyurea to be discontinued. He would need some infection prophylaxis, which he kind of has, but like we need to change the console, post-console. As part of the CINV prophylaxis, is that brand dose is too high to be given IV, so keep the C prolongation, so we either need to change that to oral or decrease his dose. The dexamethasone dose is 8 milligrams. This 12 milligrams was appropriate for the first day.
Good. So kind of a lot going on there, which is a good thing. Patients are pretty complex. So for the AML, let's go more systematically and talk about the chemotherapy, and then talk about the prophylaxis. We actually are going to defer tumor lysis to a separate problem just for the ease of everyone following the discussion today. Again, it would be okay if we put that as a sub-problem, but I think it's just a little easier to go and kind of tackle the AML and the chemo, which includes its supportive care, and then other technical diagnoses separately. So starting with the goal, so inducing a remission of less than 5% blast is definitely the goal. And then optimizing supportive care, I would add as a separate goal because you're going to talk about even giving some specific recommendations, right? So for the chemotherapy specifically, is there anything in the plan we need to do? Did any group find anything about the chemotherapy or an intervention or action you would do as a pharmacist with this patient?
They need to test for the FLT3 mutation.
Good. So looking for mutational analyses, as we talked about pharmacotherapy, there were some targeted drugs that may be added either up front or in second line, depending on those results. So molecular testing, looking for that. And like we talked about, pharmacotherapy is not always available right away. There's a delay in the test result. So that's something to keep on your plan for the future to follow up on. Great. That's excellent. Anything else?
You should only give one.
Sorry, non-Augusta, go ahead.
The Donaruba dose, you should only give 75% of it due to the bilirubin.
Okay, so double checking the chemo doses against any laboratory markers, so making sure you have your LFTs at baseline, and then is there any issue with that is one thing. And then there was a comment here in Augusta, I also want to make sure we talking over each other, make sure we were okay.
Sorry, that happens.
Okay.
Then we did a baseline echo or MUGA for his heart function because he's on an echo cycle.
Good, so in the chart there wasn't a note from cardiology or a result that showed you that the patient had had an echo, right? So we didn't know what their ejection fraction was. That would be something you'd look for if it was done at an outside hospital where they were transferred, and you get those paper records, something like that. So checking their ejection fraction, making sure they're eligible for that anthracycline would be something to do before the drug is dispensed. Anything else? It was said earlier, I believe, in the chart, it was supposed to have fallen off and been discontinued. So we go to the meds tab and look at what is here. Scroll. So the hydroxyurea, since it has not been discontinued, should be. That's something that I think I missed in the update this year. So we would want to stop that now that we're starting our intensive cytotoxic chemo. It was appropriate to get them ready for chemo, but now, as we discussed in pharmacotherapy, that's not a long-term maintenance drug, it's just a temporary Band-Aid. So that would be discontinued as we start the intensive chemotherapy. So there were some laboratory things to look at, there were some pre-chemo checklists to look at, and there's some calculating chemo doses, as part of the checklist to look at for the AML chemotherapy main part of the problem. So then the next thing we have to look at is supportive care, which was already somewhat mentioned, but let's go systematically through that. So the first major drug-related problem that we see with the supportive care was what? What error did we find? It was already mentioned, I just want to make sure we're highlighting that as a...
The Zofran dose was too high for IV.
Good, so the maximum dose of IV ondansetron was 16 milligrams to reduce the risk of QT prolongation. So they had ordered a dose that's only acceptable as oral. So we would need to correct that before administration to the patient because that's a wrong dose error. So that was definitely a critical thing you would need to identify as the pharmacist. So they can either change it to the lower IV dose or they could switch it to oral and leave the dose the same. Either one could be acceptable, but leaving it as is a wrong dose error. And there was another error that was mentioned earlier, so I want to make sure we address that as well.
So the dexamethasone dose?
Okay, so tell me more about this dexamethasone dose.
It's too high, particularly with the patient being on the foxaprepitant, because there's a drug-drug interaction there.
So what is the recommendation for the dexamethasone with the aprepitant, fosaprepitant doses?
8 milligrams PO.
On what days?
Days 2 and 3.
Right. So we would have separate orders for the first day and the subsequent days if we were doing that. And so looking through the chart, we only have our one dose, but we do have the fosaprepitant once it's already been given. And then there's a third. Oh, no, there it is. I'm just making sure we have everything. Perfect. And then there was a third supportive care thing that was alluded to earlier that we would also put within this problem. So other than CINV prophylaxis, what other supportive care is necessary that's affiliated with the chemotherapy order?
They were on fluconazole for antifungal prophylaxis, but with AML, posaconazole or voriconazole is preferred.
Great, so thinking about infection prophylaxis, which would be on our chemotherapy order, the patient is on the incorrect azole, so we need to switch it, as you said, to posaconazole, which is the recommended. So what is posaconazole covering that fluconazole is not? Why do we need broader coverage? When I say broader, what am I talking about specifically? Good, so mold coverage. So fluconazole only covers Candida and has some gaps even within the Candida coverage. But your broader azoles are also going to cover your molds, including Aspergillus and Rhamposa, even some Euchroalis species. So we need that broader coverage in these patients based on the guideline recommendations. And how is fluconazole dosed? How would we need to make sure the physician ordered it?
milligrams Q12 day one, and then 300 milligrams the other day after.
Excellent. So in this particular patient, that's one option to DC fluconazole and start that. Did anybody have an alternative drug recommendation for a patient-specific reason? No, I'll give you a visual hint. Ah, that was ours trying to go. That's not the right visual. Wait. There we go, sorry. Anything about this piece of information out of the chart that makes you maybe want to pick a different option, and what would that option be? So we just said that we were going to switch from fluconazole to posaconazole based on the clinical data and guidelines for broader coverage. However, what about this patient thinks that azole is potentially not the best choice?
Hepatotoxicity?
Right, so we know that the azoles can cause hepatotoxicity. This patient already has elevations in their baseline total bilirubin at 1.7, which is above normal. Their AST and ALT are normal. So this is kind of a question to ask. I don't believe in this case you would have to avoid an azole, but it's something to consider when you start to have on your plan to monitor closely and discuss with your physician. If a physician was worried and said their T-bill is already baseline elevated, I prefer to avoid any hepatotoxic meds and see what happens, what would your alternative be that is not inappropriate?
Mycopungin.
Excellent. So in a kind of candid, like mycopungin at a prophylactic dose would be an appropriate alternative. We would not keep that on unless their hepatotoxicity, worsened or continued. So this is what I would say is a clinical practice gray area. There are no hard and fast that at a certain T-bill you have to definitely switch. It's something to consider. Are you going to start the POSA and monitor, or are you going to start with a kind of candid and as things resolve, switch to the POSA at that point? That's a discussion I would have with my physician. I personally would start the posaconazole and only switch if it worsened. That would be my strategy. But I don't believe in the setting of a baseline elevated lab that it's wrong to start with the echinocandin and then switch to the more appropriate therapy as they resolve. Because you don't know where this patient's headed. As you treat their disease, this might self-resolve in a few days, or it could get worse with the concomitant hepatotoxic drugs they have. And hindsight's always 20/20. But as long as it's on your plan that you're monitoring and you know what the guideline recommends and what the alternative is, I think you could argue either way. Both are an acceptable choice. Any questions on that?
I have a question about dexamethasone dose. I didn't quite catch. So what should it be for the 3 days?
So the dexamethasone dose in clinical practice, I'll tell you, is variable. There are places that don't dose reduce for the NK1s at all. I don't think we talked about that in pharmacotherapy because I was reserving a little bit of those clinical discussions to happen elsewhere. The updated guidelines are not necessarily recommending you change for every single NK1 anymore. I will post that. That was not what we learned earlier in the semester because it's changed. So I feel like I don't want to confuse people what they learned earlier and what's happening now. So I will post the updated information on that chart. I'm taking a note right now to myself. But it depends on whether you're going to follow the official guidelines or the new information that's coming out. And I feel like in my practice, we're following what's new, but that's not what I taught you early in the semester. So I'm trying not to confuse people. But I will post that today, this afternoon, for you all, because there is, so next change in the correct, I just took a note on myself. There is difference in practice as to whether people feel like it's really necessary or not.
Would it be appropriate to look in LexiComp, or do you want to follow like a?
So you're not going to see necessarily in LexiComp the total dose strategy. I would look at the old ASCO guidelines, what we talked about in class, and the NCCN guidelines are what I think is updated more frequently and is more relative to what happens in the real world. So most physicians are going to look at the NCCN guidelines because they're updated more quickly, and that's more related to what's actually happening. The ASCO guidelines that we learned in class are kind of the formal evidence-based reference that doesn't have anybody's opinions in them. So that's what we did for the test, just so it was a hard and fast, everyone was playing by the same rules kind of thing. But that's not really always what we follow because they may be a few years outdated and there's other information, or people are practicing different and showing that there's no difference in safety or tolerability. So you don't do what's labeled, you do what people have found subsequently. So the last part of the primary problem of AML, we have our goal, we have our plan. Now we have to decide what we're monitoring. I obviously just gave away one of them. Yes.
Would we add those corticosteroid eye drops to this patient, like part of supportive care because of the cytarabine?
So does anybody know the answer to that question? Do we need steroid eye drops for this chemo regimen?
Is it for high dose?
So a bunch of people here in Augusta said no. So the steroid eye drops are only for high dose cytarabine. And so this regimen is just the 7+3, so it's 7 days of the continuous low-dose cytarabine. It's not the HiDAC. And so only in the consolidation of HiDAC do you need the steroid eye drops because it doesn't leach out into the tear ducts until you're very high doses. So at normal low doses, the excretion isn't going to cause a problem to the eye, but at the high doses, the higher concentration of excretion can cause the conjunctivitis and irritation, so you would need the eye drops. But in this case, you would not because the dose is low enough. Good. So to round up this problem, is there a group that wants to tell us the rest of the monitoring? We already said we need monitoring for the LFTs moving forward, but what else would be necessary because of the chemo and the supportive care?
EKG. Is this a group or is this anyone?
Anybody.
EKG.
So an EKG would not necessarily be required moving forward. None of these specific chemotherapy drugs require EKG monitoring. So when we talked about APL, we talked about our arsenic. So there are some drugs that are related to that, but in general, 7+3 by itself in this scenario, we don't have a specific indication for that.
Donna Rubison, you don't have?
What about something for the hyperuricemia?
You mean monitoring wise?
I mean, do they need to be on like uricase or allopurinol or something?
So what specific problem would you put that under? What would you title that problem?
I just had it as hyperuricemia, but one of my teammates is saying tumor lysis syndrome.
Good. So one of the next problems will be tumor lysis syndrome, so we'll circle back to that because that definitely is one of the next more high priority problems. So we're just about to get to that. But monitoring of the AML itself, other than tumor lysis and any of the other drugs, what else do we anticipate you expect you need to look at moving forward? What's the main thing this chemotherapy is going to affect? Right, so we anticipate with intensive cytotoxic chemotherapy, myelosuppression is a main adverse event. We talked about that in harmful therapy. So we expect the blood counts to go down. So you can expect to monitor a low white count, platelet, and hemoglobin, having on your plan to look whether the patient needs transfusions. And you already have infection prophylaxis, and you're going to have another problem in a minute you're going to tell me about that has its own monitoring related to the risk of infection. But daily CBC is needed. so you can look for their blood counts because you anticipate myelosuppression happening from the cytotoxic chemo. We said LFTs are needed, but obviously a daily CMP would be needed, right? So some of these drugs can be renally cleared, so we would need to check their serum creatinine every day, make sure everything is still dosed appropriately, if there are no problems. And we're going to get to the electrolytes out of that tumor lysis problem in a moment. And then monitoring of other side effects of chemo. So 7+3, other than myelosuppression, what are the main side effects of the anthracycline and the cytarabine at this lower dose?
Nausea, vomiting, mucositis, diarrhea, and bleeding.
Okay, so nausea, vomiting, the GI toxicities from cytotoxic chemo. The bleeding kind of goes with the myelosuppression, right? So as they become myelosuppressed and lower hemoglobin, lower platelets, they can have bleeding in that way. And then what was the third thing you said?
Mucositis.
Right, so mucositis can happen from the cytotoxic chemotherapy as well. It was alluded to earlier that we would need to make sure that baseline echo was normal before dispensing the chemotherapy because the anthracyclines are cardiotoxic. So moving forward, monitoring for signs and symptoms of cardiomyopathy and heart failure would be necessary because that even if you have a normal echo, you could still get the cardiotoxicity. So we want to monitor for that cardiotoxicity acutely and long term as well. Did anyone have anything else they wanted to monitor for the AML problem itself?
Do I get a lumbar puncture since he has the? Do you want to get a lumbar puncture since he has like the chin tingling and CNS symptoms?
Good. So we talked about AML patients only need to be assessed for CNS disease if they present with potential signs and symptoms of CNS manifestations. So if you saw in the note that this patient had any of those chin numbness, headaches, issues like that, they would be indicated to get a lumbar puncture to assess for CNS disease. Contrast to our ALL patients where every patient should get that. This is only symptom driven. So you need to either look at the note or ask the physician, if you didn't see it documented in the note, if they had evaluated for it so that they could make a determination if that test was necessary.
If he did, when like if his INR is high, when do you not do a lumbar puncture?
Good. So a lumbar puncture timing is not in practice defined. It has to be a certain time point. We would probably give this patient, if we needed to do an LP, some vitamin K, recheck, and then do it. We would also, in the case of this patient where they come in with a high white count, we wait until it comes down a little bit because you don't want to what's called seed the CNS. So if you do a lumbar puncture and it's a bloody tap, you can introduce blood into the CNS, which if there's leukemia in the blood, you literally just put leukemia into the CNS system. So then you don't really know if your test is accurate or not. So people with very high white blood cell counts, we don't do the tap right away. We wait till the white count comes down, and then we do the tap so that we're making sure we're not having a problem by introducing the disease itself. So it's not required to be at a specific time point, but we do want to make sure all these labs are tidied up first. In the case of AML, in this patient, I would probably give them vitamin K to make sure the white count was down at least less than 20 or 30, and then we'd be able to do the LP. So the timing of it isn't like emergent, has to happen right when they walk in the door. You have the luxury of waiting a little bit. Okay, so that's definitely the primary problem. There is a debate over whether the next two problems, I would say, could easily be problem number 2 or problem number 3, either one. So does any group have what they had as their next problem?
He had tumor lysis syndrome.
Good, so I definitely think TLS could be the next problem. Did a different group, or did any other group have something different? Everybody had TLS? Really? What other oncologic emergency did this patient have as a diagnosis? Right, so febrile neutropenia is definitely another condition this patient has that you could argue as problem number 2. I personally think as long as they were number 2 and 3 in either order, it's perfectly acceptable for rotation presented in this patient. They're both oncologic emergencies, they both require prompt intervention. You could argue either way. I don't think there would be a specific, you have to say it in any order. as long as you fully do both problems, that would be acceptable. So since TLS was kind of the more common answer, we'll start with that one, and then we'll do febrile neutropenia as problem number 3. But I do believe these as oncological emergencies that have acute interventions are going to take preference over some of the general supportive care of the patient's other medicine conditions that are going to be a little lower on our problem list that we'll get to in a few minutes. So for tumor lysis, does the group want to tell us what is the goal of managing this patient's tumor lysis? Savannah, I don't think I've heard from y'all yet, maybe? You know, jump in. You're also teeny tiny on my screen, so I can't tell.
I think they left. Did they?
There's a few people in the back, right? Kelly texted me and said that most of them left. So I will take the one that changed. Almost over. Like they did more specialty now.
We just have to make sure there's
Adequate hydration.
Adequate hydration, okay, so I heard you, but it broke up at the end. So the goal, I think that's a good intervention to make sure of, but the goal for TLS would be, anybody want to kind of fill in that statement?
Safety key. Do you want to say
would
the
be to normalize the electrolytes and get that urate level down.
Good, so managing the laboratory TLS is your primary goal, and by doing so, you're preventing any clinical TLS from occurring, right? So the problem with tumor lysis syndrome is the electrolyte abnormalities that can cause clinical TLS. So the goal is to resolve the laboratory TLS to prevent clinical TLS. Now, how we do that in our plan was already alluded to. We need to make sure the patient's on adequate hydration. And so, let me see if I can get back to that tab. Does this patient have continuous IV fluids running? When we scroll to their med list and we see no. So I think that's a great catch to say, patients at risk or in TLS, they need hydration. So adding hydration would be your first intervention. Does anybody else have other interventions specific to the laboratory TLS that you would also recommend?
You could give Respiricase 6 milligrams IV times 1.
Okay, I agree, fixed dose Respiricase based on what lab parameters specifically?
The uric acid was 8.2, so greater than 8.
Perfect. Anything specific in monitoring? I'm jumping ahead a second, but I think it's really important to always have this thought together in your head for the repeat uric acid level. I know this is only exam pharmacotherapy, so I'm pointing it out. What's special about uric acid levels after you've given Respiricase?
Do you have to keep it on, keep it cold or on ice?
Exactly. So anytime you give Respiricase, it's an enzyme that's going to keep working in the blood. So if you don't keep it on ice, you're going to have a falsely low level. The blood just sits there for a while. The drug keeps working in the blood, but that doesn't reflect what's happening in the patient. So you need to keep it on ice to keep the enzyme from working so you get an accurate at the time of sample. I know that's monitoring, but I always feel like anytime you give Respiricase, you need to tell the provider how to order the next lab sample so that it's accurate. I get uric acid level of less than 1.5. Almost always that's because it wasn't done on ice. So it just sat for 2 hours before they ran the sample, and then there's no uric acid left in the blood because the enzymes continue to work. Other than adding hydration, giving Respiricase, what's the third intervention for the current laboratory TLS?
Would you give Kyaxalate for the potassium?
Yes, and if you scroll through the med list, they actually have already ordered it, and it says it's completed, so the nurse has already given it. But that, if they had not done, would be an appropriate intervention for the hyperkalemia, as you just pointed out. Do you think, based on the patient's hyperkalemia level, that they need a follow-up any sooner than tomorrow morning? Would you request your physician to check it in 8 hours or 12 hours? I agree. So based on the level of hyperkalemia, I don't believe that this patient requires an emergent, 5.2 is barely above the reference range. It's not critically high. It's not something that would be associated with current arrhythmias. We don't see anything in the chart. You could ask the physician if they're having any clinical problems, but at 5.2, I can tell you clinically, they're not having problems. I've had people with potassiums of, 6.2. That's the person you want to make sure that your intervention worked and that you follow up in a few hours to see if you need more interventions, because you don't have to load your waiting 12, 24 hours. But in this case, it's only slightly high. Give an intervention, check them tomorrow, that will be fine. So I agree, we wouldn't have to do that. Now, if the provider ordered it, that's under their discretion, that would be okay, but it's not necessary. Okay? So we kind of have our goal and our plan, so monitoring. I already talked about the uric acid sample on ice. In addition to that, what else do we need to monitor, specifically for this patient, and how frequently and for how long? We gave away a little bit of it, but tell us more about it. If the patient has a diagnosis of laboratory TLS, what specifically are we monitoring and how often? For anybody in Albany, y'all are off the dark screen for me. I can't tell.
Can you,
Whoever was talking to guys cut out. Sorry.
can you repeat the question?
Yeah, so for our diagnosis of tumor lysis syndrome for monitoring, we've already said that we need to repeat uric acid tomorrow on ice. We said we need to repeat potassium tomorrow. What other laboratory parameters are we monitoring and at what frequency and duration? Just to finish out the monitoring part of this plan.
I believe we need to check magnesium, but I don't know if that's everything we need to look at.
So magnesium is actually one of the few electrolytes that doesn't significantly get altered in tumor lysis syndrome, because it's not an intracellular component that's significantly released when the cells lyse during the acute TLS picture. There are some other intracellular components in addition to potassium and urate that are released. So what are those? We mentioned these in pharmacotherapy this morning, so that's a hint.
Calcium and phosphate.
Good, so calcium and phosphate. So your phosphorus goes up, and because it binds the calcium as a precipitate, then your calcium also goes down. So you will also want to follow tomorrow on their phosphorus level and their calcium level. If they might be normal today, but again, we're starting chemotherapy, we're continuing treating, they can go into TLS, so that could change. They could get more fulminant laboratory TLS in the morning, which may have different interventions. You don't want to just follow the problem that you have, you want to anticipate what else could be a problem and follow that tomorrow as well. So monitoring of potassium, phosphorus, calcium, and uric acid would be the laboratory parameters, two of which we're monitoring because we made intervention, and two of which we're monitoring because while we don't have a problem, we could end up with a problem, so we want to make sure we anticipate that and have a plan for what we would do. I agree with what was said earlier that morning labs are fine. So how long is typically the duration of tumor lysis with cytotoxic chemo? How long should we have to be worried about this? A day, a week, a year? Obviously that was egregious, but
3 to 4 days after the induction of the chemo.
good. So the first 3 to 4 days is your highest risk with cytotoxic chemo. So in a few days, if they're not in tumor lysis, they're not going to be in tumor lysis. Remember, you're killing it, the body's inability to handle the massive lysis of the tumor bulk. As you kill off the cancer, there's less and less cancer to be killed, so it's not so much that your body can't handle it. So it's definitely an acute problem that should resolve within a few days, especially if you have good monitoring and management. Now, if you don't monitor it well, it can last longer and become clinical TLS, but we are going to do a good job of monitoring and intervening, and we're going to prevent that from happening. Any questions about the TLS? Yes.
The raspberry, do you, my mic doesn't work, continue it for the 3 to 4 days after, or do you stop it when you stop that and just monitor it for
So a question here, and I guess, sorry, this mic doesn't work, is about the rasburicase duration. So rasburicase, when you do fixed dose, is always one dose and monitor the result. You only give another dose if they still have hyperuricemia. That is extremely rare, like less than 10 or 15% of people are going to need a second dose. Even if they go into TLS, rasburicase is extremely effective. And once you've dropped it down and kind of chewed up the urate that you have out there, you typically don't need to give another dose. Now, again, there are some patients that do need that, but that's what the repeat level is for. That's going to dictate what you do next, but you would not routinely give it. Now, if you happen to work at a hospital that does the FDA-labeled dosing that's the weight-based in several days, if that's their policy, then you would follow that. That is extremely rare because that's not cost-effective at all, and there's so much data showing fixed dose is as effective, if not more effective, and so many people don't need future doses. I'd be shocked if you had a rotation somewhere that did, multiple days with base dosing, but I guess it could happen. But I would doubt it. Any other questions about that problem? Again, some people may put TLS underneath their AML. I think it's its own diagnosis. It's its own ICD-9 code or ICD-10 code now in the billing, so I would put it separately. But as long as you completely covered it from all the interventions and all the monitoring, I believe that would be sufficient. But because it's its own diagnosis, I would put it as a separate problem on your list. Same with the next problem that was alluded to, which is febrile neutropenia. That's its own diagnosis, its own ICD-10 code, so I would make that a separate thing. So let's do that one next. So our third problem is febrile neutropenia. So does the group want to tell us what our goal is with this specific diagnosis?
So we want resolution of fever and to prevent sepsis and mortality.
Good, excellent. So our acute goal is to resolve the current fever and want to avoid them becoming septic or having a death due to an infection. Perfect. So in order to do that, we need to make several interventions. So when a patient has neutropenia and spikes of fever, what is the very first thing that needs to be done? And this is not necessarily by the pharmacist, but I want to start at the beginning because febrile neutropenia is really important. What's the first thing that needs to be done?
Get cultures.
Okay, so I like the order cultures. That goes along with the full answer I'm looking for. So cultures before antimicrobials is obviously very important. So I agree with you. Cultures from where is a detail that's important.
From the blood.
Okay. How are we going to get that blood out of the patient? Where are we culturing specifically? I'm not nitpicking. This is actually really important.
Isn't it peripheral and central from each lumen or access site?
Yes, exactly. So if you have multiple IV lines, every single line has to be cultured in febrile neutropenia, and they need a peripheral stick. If they happen to not have any lines, which never happens in oncology, then they get 2 peripheral sticks. But that's not really that common. So every line has to be cultured, and you have to have a peripheral stick. And the reason for that is we need to know if it's a class serum. Is this a catheter-related infection or not? And you can't determine that if you don't have a peripheral stick and your line cultures. And you also don't know where you're all infected if you have multiple lines. You don't culture every single line. And it's every lumen. So if you have a triple lumen Hickman, you have a central line with 3 lumens sticking out. Every single lumen has to be cultured. So you can have multiple cultures the same day, and they are flagged as port, blue lumen, red lumen, peripheral stick. So you'll know where they came from. They do label them that way. So that's really important. Good. So cultures from every single line site plus a peripheral. What else happens when they're ordering these cultures? Before they get to the therapy step, what else has to happen? They should not get a call from the nurse that says, hey, your patient's febrile, and they say, okay, I'm ordering cultures and antibiotics. They missed something. What did they miss? And I'll give you a hint. How do you know which antibiotic to order? Okay, so we have multiple empiric broad spectrum options. How do you know which one is the best for that patient? I heard something.
Their symptoms,
Okay, so how do you know where the patient's having any symptoms?
like if they're coughing, it could be their lungs or stuff like that.
Okay, good. So how would you know that? Like,
observe the patient?
Right, you need to go, someone, not you necessarily, someone has to physically assess the patient from head to toe in febrile neutropenia at the first fever. And that is very important. We have algorithms that say what to do in guidelines, but you cannot separate the patient from the guidelines. There are options and guidelines, and how do you know which one to pick is based on your patient assessment. So if you have not assessed your patient, you don't know what to pick. You shouldn't just follow blindly a random choice, right? It should be based on the patient. So before we can decide what empiric therapy to start, we need to do a head-to-toe exam. And so what are some of the things where the patient could be infected that would change your antibiotic choice? So think about it. What are the couple of options empirically to treat febrile neutropenia up front? What are the drug choices? Guidelines give you some options, so what are they?
Susan or cefepime if they're inpatient.
Okay, so cefepime and Zosyn, I can't say that out loud, so I'm just not going to try. And then there's a third option that's broader. Yep, a carbapenem. Good, excellent. So several people got that. So you have your cefepime, your Zosyn, and your carbapenem. So we'll just say meropenem is the formulary drug I'm used to. So of those three, how would you know which one to pick for your patient? What does Zosyn cover that cefepime doesn't?
Anaerobic.
Anaerobe. So what site of the body could a patient have an infection that would make you want to pick that drug?
Abdomen.
Good. So they have any abdominal pain. That would be one reason. What else could have happened to the patient that makes you want to cover anaerobes? It didn't happen in this case. I'm just trying to have a walk you through this.
Animal body.
Not right.
Animal.
I don't know. I really read that.
Abdominal issues can get into what other organ? In what way? So bugs from your gut can get into another organ because something happened.
UTI.
If your patient aspirates, it's an aspiration pneumonia, right? They can end up with anaerobic either gut or mouth bugs into their lungs. Again, that didn't happen here, but I'm just walking you through. That's why your head-to-toe exam matters. So thinking about coverage between your different antibiotics and sources of infection. Also, we were just talking about our 3 empiric options that are first line. You may have to add additional therapy, right? So what would have to happen with this patient for us to add something else? Mr. Kennedy.
If their fever worsens.
Not necessarily. Remember, it's time to effervescence and febrile neutropenia in about 4 days. So persistent fevers by themselves do not mean you have to broaden coverage. You broaden coverage because a patient is
If the patient's hemodynamically unstable?
right. So the guidelines say that you only start with your anti-normal drug, your cefepime, Zosyn, meropenem, and add something if they meet criteria. And there's a list of criteria there for what 2 types of drugs. We can broaden gram-negative coverage with what? And aminoglycoside, we can broaden gram-positive coverage with bank. But they have to meet indications for those. You don't just start triple therapy on everybody. That's not appropriate. So if they're hemodynamically unstable, you add both, typically. If in your assessment their IV site looks bad, they have cellulitis, are you more worried about gram-negative or positive? Positive, so then you need to add your vancomycin. If they look like they have a pneumonia and healthcare related, potentially thinking HCAPs, again, not necessarily related to this patient, but then you would add that. So right now, the patient's vitals, okay, they have a relative slight hypotension, but they're not meeting the old SIRS criteria. Maybe they just need some hydration at this point. Obviously, we already talked about they're not on hydration, so that's a problem. But while they have a fever, we don't have current vitals. So getting that and deciding what antimicrobials they need will be important. What's their physical exam? What are their current vitals? Because whether they are or not hemodynamic unstable is going to change what drugs you recommend, right? Yes.
The patient is not actually neutropenic yet. Do we just think they're going to be eventually?
Great question. So neutropenia is related to what cell in the body? Neutrophils. So what kind of cancer does this patient have? AML. So the M stands for myeloid, right? So they have a cancer of their myeloid lineage. Do the neutrophils they have, are those cancer cells or normal cells? They're cancer cells. Do cancer cells function normally? No. So this is actually what we call functional neutropenia. And that's a really great point that isn't in like the febrile neutropenia guidelines explicitly, but everyone in the oncology community just knows it. So this patient is what we call functionally neutropenic, and yes, we know they're going to become neutropenic from the chemo, but right now their white cells don't work. They're the cancer cells, so they can't fight off the infection. So we're going to categorize them as febrile neutropenia. That is a really good question. So for this patient, for their febrile neutropenia, have they started anything? We scroll through their med list and we don't see anything. But we don't have a physical exam and we don't have current vitals. So we can't really say right now what the best choice is. We know they need cultures, we know we need an assessment, and then we can order a stat antibiotic. So this has to happen very quickly. So if I saw that fever, I would immediately ask my physician, do they have any source of infection? And ask the nurse, what are their current vitals? And then within 5 minutes be able to provide a recommendation of the choices of drugs we just talked about, between which gram-negative is appropriate coverage, and then do we need TOBRA, do we need vancomycin? You don't have enough information right now to answer this question. Now most physicians are going to just start cultures, cefepime, go see the patient. And they know their nurse is going to draw the culture, start the cefepime, and they can add on more therapy if they need to. That's typical to make sure the patient gets the antibiotic quickly because this is an oncologic emergency. But after the first dose, if their evaluation shows something and you feel like it's appropriate to switch based on the source of infection, that's fine. But remember, this is an emergency. We do need to do this quickly, so this wouldn't be something you would wait, until you got the patient around. You have to interrupt and say, hey, we have this new fever. Can we address this right now? This is a timely problem that you would need to intervene on. So your plan here is more gather information and quickly synthesize and make a treatment plan than it is you would know walking into this class what to give the patient. But as you get new data, you have to be able to quickly assimilate and make a decision. So if they said the port looks bad and the patient's complaining of pain at the port site, you immediately would say, can we start vancomycin? That's appropriate for the guidelines. That's why I left this problem more like open-ended, because that's what happens in practice. You get new information and then you have to change what you're doing. Questions about this? Anything else you guys had for this plan or monitoring? I know it was a little more esoteric on purpose, because things aren't, I have all my data, I go it around, I'm done. If I have some data, I get new data, this is what happens as the day goes on. So monitoring for febrile neutropenia, is there a group that wants to tell us, let's pretend this patient was clinically stable, they didn't have any source of infection, we're considering them functionally neutropenic and they're febrile, and everything is kind of easy peasy, simple. So the physician says, I want to start cefepime. We do the cefepime. So in that scenario, what would you monitor moving forward?
I guess monitor their culture results and then also monitor their fever. And then for the cefepime, you want to monitor renal function and make sure you're getting creatinine clearance.
Good. So for febrile neutropenia, we definitely need to be monitoring their fever curves. And we need to look at that culture results every day. So if we can culture today all the lines, then is anything growing the next day, the next day, the next day? We need to keep looking at that. I agree for the drug. So what are the specific side effects they're monitoring? So for cefepime, it needs renal adjustment. So keeping up with your serum creatinine and creatinine clearance to see every day if you need to make an adjustment. What dose should this patient be started on for cefepime and why?
Is it 2 grams every 8 hours? I know their renal function might be a little off because their serum creatinine is very low, and so you might think that their creatinine clearance is a little bit lower than what it is, maybe, but I think 2 grams every 8 hours is.
Yeah, so 2 grams every 8 hours is the appropriate answer, and we need that dose to cover what bug?
Pseudomonas.
Good, excellent, Pseudomonas. So we need anti-pseudomonal coverage, so we have to use the appropriate dosing. The patient's labs don't show any renal dysfunction, so having a low creatinine, yes, for certain calculations, you would round up to 0.8, 0.6 or 0.8, depending on your institution's policy for calculating creatinine clearance. But even if you did that and calculated his creatinine clearance, you would still have a normal creatinine clearance that did not require a dose adjustment. Our institution doesn't ramp up for the purpose of this particular drug, but if you had an institution that did, you would still be within the range. But yes, monitoring creatinine to see if you need to adjust that dose over time is appropriate. So we had temperature, we had culture results, we had the cephalene. What else? There's something else that's very important to monitor moving forward for Febrile neutropenia. We went through this with the assessment initially, so it's part of our ongoing monitoring. It's 2 things. Exactly. So their vital signs might be stable and normal now, and they're on cephalene, but if overnight repeat vitals come back and their blood pressure is 70/40 and their heart rate's 120, you're probably not going to just continue with cephalene, right? You're going to do something else. You're going to make another intervention. So this isn't a static problem. This is an ongoing problem. So vitals are really important because they can crash and go septic at any point. So that's something that may warrant change in therapy as we go. So vitals are extremely important. As I said, repeat fevers or consistent fevers, if you're clinically stable, don't necessarily mean you need to change anything if your patient's asymptomatic. So also knowing, do they have any new symptoms? Maybe they didn't have any problems, but the next morning they complain that every time the nurse uses their line, it hurts with flushing, or it starts to get a little red and puffy. Okay, well then maybe you need to add on that vancomycin now. It wasn't appropriate before, but now it is. So depending on their symptoms, you may change something. This isn't part of this case, but they can have symptoms of other infections, right? They can have oral lesions that get swabbed and come back as HSV reactivation. So then maybe they need treatment dosing acyclovir, and it has nothing to do with bacteria. So evaluating their symptoms and their vitals every day is important because patients don't stay the same. They're changing all the time. So you have to go with that and adjust your therapy. So vitals and symptoms are ongoing monitoring. We talked about blood cultures. So other monitoring, does anybody want to do any other cultures of any other sites based on the information out of the chart that you've seen so far? Yes or no?
Don't you usually do like just a baseline analysis so that you know if they don't have a very infection?
Okay, so if we got a urinalysis, what would you be looking for? Like what out of the urinalysis would make you change anything? You're ordering your analysis to look for what?
Bacteria?
So if you saw bacteria, does that mean they have a UTI? Not necessarily. There's 2 diagnoses if you have bacteria in the urinalysis. What are they? UTI and asymptomatic bacteria. So what's the question you should ask before you order your analysis? Is the patient symptomatic? So we have nothing in the chart to suggest this patient has symptoms of a urinary tract infection. So I would argue you should not order a urinalysis or a urine culture because it's not indicated. What is the other potential source of infection that could have some workup if the patient were symptomatic? It's a quite common infection in the hospital. We don't culture outside of a port. We would only get the blood culture from the port. If they had like symptoms of like a line infection, you only culture the blood. You don't actually swab the skin around it because you're just going to get a bunch of skin for it. Doesn't really help anything. Now, if they had like abscess that you like I and D, you could culture like the actual drainage, I guess, but that doesn't really happen, mostly because patients who end up in neutropenics don't make pus. They don't have those symptoms because you have to have an immune system to mount that response. So that doesn't really actually happen.
Like a chest X-ray and stuff if they have coughing symptoms.
Okay, so if the patient has respiratory symptoms, would we want to get a chest X-ray, and or if they have a productive cough, a sputum culture? If they're symptomatic, yes, but just routine chest X-rays don't really tell you anything. Kind of like routine urinalysis. You don't want to look for something, unless you have a specific symptom. So in this patient who had no signs and symptoms specific to infection anywhere at the time in which the chart you were looking at it, would only need the blood culture. They wouldn't need a chest X-ray necessarily. They wouldn't need urinalysis. They wouldn't need a lumbar puncture just to look for meningitis. We wouldn't do any of those tests unless they had an indication. And again, tomorrow or the next day, if they present with different symptoms and complain of things, that may change your management. So you want to keep those in the back of your head of what symptoms should I be asking my patient about or asking the physician if they evaluated for, because then it relates to the workup you want to recommend and any drug therapy changes that correlate with that site of infection. So at this time, I didn't give you any signs and symptoms, but I wanted to walk through what would happen next and next and next, because these problems can start simple and then blossom to be a lot more complicated, where they can easily self-resolve. We have to kind of anticipate what happens next. Any questions on febrile neutropenia? The last part of febrile neutropenia, which would not be relevant in IPC because you're doing more of a how is the patient now and what exactly you're recommending now and not a what you're anticipating for in the future. But I want to point it out because this was a significant miss on the pharmacotherapy exam recently, is what is the duration of therapy of the empiric antibiotic we chose? We gave cefepime in this case. So how long would the patient stay on cefepime?
Until the patient's been AZ-raw for 24 hours, 48 hours, and the ANC count is rising?
Okay, so define rising.
Above 500.
For how long?
48 hours.
Good. So if you to have your neutrophil count above 500 for 2 days is the minimum definition of count recovery, and in transplant you're going to see it's called engraftment. But you have to have neutrophils above 500 to have your counts recovered at a minimum. So until the patient's counts come back to that, they have to be on an anti-seminal coverage, right? If this patient, let's say, was diagnosed with bacteremia, what else would we have to include in our statement for duration? So count recovery and...
Negative blood cultures.
Okay, so people are going to say you have to have negative blood cultures, and that helps you dictate what? What's the duration of therapy for bacteremia?
7 to 14 or 10 to 14.
So depending on what bug you grow, the duration can be shorter. So I didn't tell you what bug they were growing, it's all exercise right now. But the duration of therapy is the minimum for that indication. So if that indication happened to be 7 days of IV antibiotics from first negative culture, you would have to have a negative culture, count your 7 days. So if you become not neutropenic before that, you can't stop because you haven't finished your full therapy for the indication that they had an actual bug growth. So if you have a specific diagnosis other than febrile neutropenia, you have cellulitis, you have bacteria, you have a UTI, you have pneumonia, you have to treat that indication for the minimum duration and until count recovery. It's not an or, it's an and. And I think that part on the exam a lot of people miss. So knowing that count recovery is an ANC above 500 and that it's the minimum duration of the infection and until count recovery, that's the duration of treatment. Now, if you just have febrile neutropenia and you don't have a source of infection, you never drew anything from anywhere, it's just until the count recovery. But if you have a source of infection, you also have to treat the minimum duration of that infection. Because some people get diagnosed with bacteremia the day before their counts come up. 1 day of treatment is not good enough, right? They have to keep going. And some people finish their course of treatment and they're still neutropenic for a week or two. You still can't stop because they're still neutropenic. So either of those scenarios happen all the time. You have to meet both criteria. Now the caveat to this, which I'm not sure if Dr. Andrew covered, is if you have a patient who meets their minimum duration of therapy and they're anticipated to be neutropenic for like weeks, like 2, 3, 4 more weeks for whatever reason, they're post-transplant or something, there is a caveat in the guidelines that says if they're clinically stable and they finish their course, you can de-escalate to antibiotic prophylaxis to finish the course. It's not a high-grade recommendation. It varies in clinical practice. But you wouldn't release someone on like cefepime or meropenem for 3, 4, 5, 6 weeks if they've completed their course. So there is an option to de-escalate. I just want you to be aware of that. But that doesn't happen that commonly. But it does come up here and there. So there is a soft recommendation that allows clinical judgment to do that. You don't want to breed resistance either by leaving people on antibiotics for inordinately long periods of time either. And some patients are neutropenic for 4, 5, 6 weeks depending on the regimen they got or the transplant they got.
can you rely on their counts? And since you said, I mean, their ANC is technically above 1,500, but they're functionally, like just because they're diseased, how do you manage that? Because you can't count on their
Good, so a
neutrophil count.
question here in Augusta is about this patient's current labs will show today, like we talked about, the white blood cell count is 6.7, and so that is not technically the patient doesn't look neutropenic when they're functionally neutropenic. So functionally neutropenic now, what's going to happen from the chemotherapy that we just discussed in our primary problem? The main effect of that cytotoxic chemotherapy is going to be to drop your blood counts. So they're going to go from functionally neutropenic to traditionally neutropenic, and then their counts are going to come back. So this patient is going to be on cefepime for at least 2 to 3 weeks, I would say, because they're starting now, and they have to get through this whole myelosuppression. And the time after 7+3 for count recovery is typically 10 to 14 days, at least. So I would anticipate that. So for this patient, yes, it's going to be a significant duration. Okay? So those are the 3 primary oncology-related problems. The leukemia, along with some of the supportive care related to the chemo, the tumor lysis syndrome, and the febrile neutropenia. Those would be the primary things that we would need to address. However, this patient also has some other comorbidities and other drugs we also need to address to be comprehensive in our management. So does someone want to tell us what the next problem on your list is? Because there are a couple more things we need to go through.
The patient has diabetes and is currently on metformin ER twice daily, but since they're in the hospital, they would probably want to change to low dose insulin.
Okay, so you recognize the patient has a diagnosis of diabetes and is currently on metformin, and you would like to switch them to the low supplemental insulin protocol. Is that correct? Okay, so tell me why you want to stop the metformin more specifically. I agree with you, but I want to make sure everyone understands the rationale for that.
For like potential like renal dysfunction, or if they're getting any labs or something that might influence or affect their renal function.
Good. So traditionally, for acutely ill patients, keeping them on metformin is not a standard in most hospitals. Particularly in oncology wards, I can tell you we always take it off and we put them on supplemental insulin temporarily. And that is because they can be on a lot of medications that are renal toxic. They may end up getting scans that require contrast that could put them at risk for having an AKI. And also, acutely, what is this patient receiving that we anticipate their blood sugars being altered temporarily? Right, so they're going to get several days of dexamethasone, and in diabetic patients, even non-diabetic patients, we can transiently have significant changes in the blood sugar. And so that might not be well managed by a routine oral drug. It might be better managed by the supplemental insulin, again, temporarily. Now, sliding scale insulin itself, as we all know, is not a good way to manage diabetes. However, in an acute temporary setting, supplemental insulin can be appropriate as long as we are monitoring it and adjusting it. So I agree, I would hold the metformin due to the risks, outweighing the benefits. I would switch to the supplemental insulin plan, low to start, and then we can monitor over time and adjust that. And maybe the patient does need basal or a meal time. It would depend on how much supplemental they're using, how well they're eating, things like that. Because with this chemotherapy we already discussed in our primary problem, it's going to cause probably some nausea and vomiting, may cause some diarrhea, causes fatigue. These patients may not be eating normally, so we don't want to overdo it and cause hypoglycemia either. When they order the supplemental insulin, what else should be ordered with it for safety? Anybody? Yeah, so the hypoglycemia protocol has dextrose as needed for nurses. So if they do an AccuCheck and the patient is hypoglycemic, they can automatically give the appropriate amount of dextrose based on the level of hypoglycemia the patient has. So those are nurse-driven protocols or automatic order sets. So anytime you order an insulin protocol, it should have the hypoglycemia portion already part of that, and that's so that the nurses quickly have access to the most appropriate thing, and there's no delay in calling a physician and waiting for an order. Those are all packaged together nicely. So that should automatically be there. If it isn't, you want to tell the physician, hey, you ordered this incorrectly, please go back and add that update to the protocol. Now with this particular patient, let's talk about the goal of therapy. What blood sugar goal do you think is appropriate given this patient's global picture? And I'll give you a multiple choice option. Do you want to be highly aggressive or less aggressive? It's like a universal level.
Less aggressive.
If you're aggressive, it's like, ah. And good. So less aggressive. So the other non-aggressive campus that just chimed in, why do you say less aggressive?
It's partially due to dexamethasone. You don't want to, also you don't want to drop their glucose too low as well.
Okay, so I didn't hear the first part about the dexamethasone, but I heard the last part where you said you don't want to drop their glucose too low in this particular patient. And I definitely agree with that sentiment. Overall, thinking about risk versus benefit. So we've just discussed all the things that can go wrong with this patient, right? They're going to have low blood counts. They are at risk for sepsis. They could have hypotension. Obviously, they aren't on fluids yet, they should be. So we have a lot of reasons why this patient is a potential fall risk. And we also know they could have some toxicities that could prevent them from having adequate oral intake. Again, meaning they may not need as much coverage from their anti-diabetes medicines. So we would not strictly manage diabetes in these patients because the risk to benefit ratio is not optimal. So you probably have learned in other classes for your general medicine, for your ICU patients, specific goals based on specific trials and the outcomes that are associated with that. That has not been replicated in these acute oncology patients. We do not know that there's benefit to having strict control. No one studied it. In practice, we're a little less intense because the risk in our minds outweighs the benefit. There is no guideline for this subpopulation. I can just tell you in general, we want to keep people what we call moderately controlled. So we don't want blood sugars above 180, 200. We want them to be controlled, but we're not shooting for fastings of 70 to 110. That's a little low for us. We get a little squirrely when that happens. So there's no set threshold, but I would say strict control is not advised because if your patient goes hypoglycemic or has a fall and their blood counts are low, let's say they're thrombocytopenic at that time, what's the most worrisome complication of a fall in someone who's thrombocytopenic?
Hemorrhage in the brain. Hemorrhage in the brain.
Right, so an intracranial hemorrhage. And that can be fatal. And so because our patients are at risk for these falls and bleeds, we do not strictly control their blood sugar. That doesn't mean we let it get wildly out of control. We don't just DC the metformin and not look at anything, right? We're going to manage it. We're just not necessarily going to manage it as strictly as you may have learned in your other medicine lectures. So with the low sliding supplemental insulin and the hypoglycemia protocol, what monitoring specifically and how frequent do we need to assess this patient?
4 times a day with AccuChecks, and making sure to do it with get AM labs and a mealtime lab.
Good. So the glucose level will be checked with our normal AM labs, and then we would also add AccuChecks before each meal and bedtime. And so based on that, those AccuChecks, then they will know how much of the supplemental to give, if any. And monitoring over time, if the patient's using a lot of supplemental, then you would be able to create an insulin regimen appropriately. Or if they're not using any at all, you would be able to discontinue the AccuChecks and the supplemental. It just depends on what happens to the patient. After their few days of steroids, how are their blood sugars doing after that? So at that time, you could adjust your regimen accordingly. But temporarily, stopping the metformin, giving supplemental insulin, and monitoring your AccuChecks to adjust the regimen as you go is the most appropriate and safest thing to do. So I know for this one, there's not a hard and fast goal with a specific guideline you can recommend, but moderate control, not strict control, is really probably verbally the way you want to put that in your presentation. Any questions on the diabetes plan for this patient? Okay,
Would
what?
you say make a,
Go ahead.
would you say make a rough goal of less than 180?
Yeah, typically, in my practice, we try to keep them less than 180. Now, when to switch from a low to a moderate supplemental scale is a little bit physician preference. So if they have consistently above 180, they're always getting their low scale, it doesn't seem to be correcting them, I will ask them to go up to the moderate scale, even if their correction factor doesn't meet the calculation. But if you're always giving them low and it never seems to impact the blood sugar, intuitively I say we should go to moderate. But that's just my personal practice. And yes, 180 is typically a cutoff. I have some physicians that want to be a little bit more strict. They say 160, and some say, as long as it's not the 200s, I'm happy. So there's a little bit of just physician preference there. And also your patient. If your patient was pretty well controlled and they only have 1 or 2 spikes here and there, maybe they just weren't eating very well for whatever reason, they ate fast food their family brought in or something. You have to kind of take that, is it a consistent high or is it just a spike because they ate candy bars, for breakfast or something. So to me, the consistency is the most important point. Just because you have one level of 200, I don't think you necessarily have to hurry up and change the supplemental scale. If that makes sense. So what is the next problem we want to address for this patient?
Treatment with their DBT.
Okay, so patient has a DBT and they were currently, as we said earlier, on warfarin, right? So what do we want to do about that in the context of what else is going on with this patient? Does anybody want to keep the warfarin on board? Head shakes here in Augusta of no. So if we need to treat this patient's DVT, what is our option that is safe and why? What's the concern of this patient? Why not keep the warfarin on board? Think back to your primary problem. What do you know is going to happen? Right, so thrombocytopenia is a concern, and it's a concern that we know isn't going to go away anytime soon. We're starting chemotherapy that's cytotoxic. We know myelosuppression is going to be an impact for the next couple of weeks. And so anticoagulation with a drug that has a very long effect is not appropriate. So it is appropriate that the physician discontinued it. If the patient has a DVT that needs treatment, what is the clinical intervention we can make with monitoring that could be safe? But drug doesn't have as long of an impact. Think alternative route of administration. That helps. Anticoagulant can stop and start the fastest.
Heparin?
Right, so a heparin drip is an option here, right? You can put this patient on a heparin drip, monitor their labs, and you can give them platelet transfusions to keep their platelets above 30 or 50, depending on your institution's threshold for thrombocytopenia. That is an option. You can anticoagulate them while giving them platelet transfusions. It's very burdensome on the lab, and the cost effectiveness isn't really there, but in an acute setting, if someone has a DVT or PE that needs to be treated, that's what we'll do. Now, if this is an older clot and the physician says risk to benefit, I would rather just stop anticoagulation and monitor and not do that. That is something that you have to have a discussion with the physician about depending on their evaluation of the patient. So this patient, can someone remind me how old their DVT was?
2 months.
2 months ago. Thank you. So this would be a clinical decision. Chances are most physicians are going to not anticoagulate them and just monitor because the burden and risk of bleeding is fairly high. Usually it's not severe bleed, but it could be. And they have to get a lot of platelets. And you can become refractory to platelet transfusions. You can become immunized against the donor platelets. So those are just a lot of risks we don't necessarily want to take. So the patient just was diagnosed with a clot last week, or they had a acute PE now while they're in the hospital, you're going to have to anticoagulate them. You don't have a choice. But you can't leave them on warfarin. That's not safe or appropriate. You have to put them on a drug that you can stop if they start bleeding, and that you have a reversal agent for, and that you can, titrate appropriately. So, in my opinion, I would not put them on anticoagulation, but if you did, you would have to make sure you were assessing their platelets and transfusing to keep them up. Now, it was asked earlier about the lumbar puncture. So you definitely can't give any intrathecal, you can't do a spinal tap in someone who is anticoagulated. So if you have a bleed into your spinal column, that can lead to paralysis, so that is not a good thing. So you need to correct their thrombocytopenia, their high INR, and typically most people say you have to be off warfarin for at least 5 to 7 days to do that. Depending on how emergent the LP was, if you corrected all the labs and was monitoring, you may be able to get away doing it earlier. But I want you to think about invasive procedures in people on anticoagulants. Look up the guidelines. For every type of procedure, there are rules about different anticoagulants, how long you have to hold them, what lab parameters have to be in what realm for them to be able to do that. So whether they're having, a laparoscopy, they're having a bronchoscopy, they're having an LP, you don't have to know all the rules for all of them, but you have to think, my patient's going for a procedure, they were on anticoagulants. How long have they been off the anticoagulant? What labs need to be monitored? Look that up. Really important. If you send someone for a test, they've been on any anticoagulant and haven't looked that up first. They could have a significant bleed and potentially death depending on what procedure we're talking about. So this is just one example of something that I think is really important. So in this case, holding the warfarin may or may not switch to heparin drip. Definitely need to monitor for bleeding with their impending thrombocytopenia. I know we're running a little short on time, so I kind of just gave you that answer, but I want to make sure you get all the information. Any questions on the DVT? There's one more problem for this patient I want to make sure we squeeze in before the end of class. What was the last thing people had on the list? What other comorbidity does this patient have?
Hypertension?
Good. So hypertension is the last problem. So the goal for hypertension is what? Same as everybody, right? What's the goal? I'm not asking for a specific threshold. I'm just asking the generic question at this point.
Less than 130/80.
Yeah, so adequate control of blood pressure. So similar to our comment about diabetes, applies here for hypertension. We want to control the patient, and if, depending on the patient workup and risk factors, you look at the guidelines and you have your threshold, that's ideal. Do we have to keep them there in this acute period where they are having a diagnosis of febrile neutropenia? They're at risk for sepsis. Right now, do we need to aggressively manage their blood pressure? The answer is no, because risk to benefit, if this patient goes into renal failure, goes septic because of their febrile neutropenia or whatever infection they may have underlying that we haven't found yet, and you aggressively manage their blood pressure, they're going to go even more hypotensive, which causes more AKI. It's a vicious cycle. So we are not as aggressive with blood pressure in this acute sick period because the risk is too high. Now that doesn't mean we let them be wildly uncontrolled and hypertensive urgency or anything like that. It just means we don't aggressively manage. If their blood pressure is 130, 140 all day, we're not going to make changes to get it less than that. We're just going to say, that looks good enough. We're happy with it. A spike a couple of times up and even to the 150s we would let happen because if you aggressively manage it and then they have an infectious problem or a tumor lysis problem that makes them hypotensive, you're just going to worsen that for no real benefit. So here, our general goal, we may have our guideline recommended goal, but as long as they're not above 150, 160 consistently, I can tell you most oncology units, they're just going to let it go. Again, if they're consistently above that, or they're in hypertensive urgency or emergency, clearly we would make intervention. but we don't micromanage the small fluctuations above the actual guideline recommendation. We're not trying to gain tight control. We just want them to be adequately managed. Typically, in my practice, I think it's good to anticipate and prevent problems. Any patient I have who could be acutely ill like this, who has blood pressure meds, I ask the physicians to put hold parameters on the order for the nurse. So if they check the vitals in the morning, they go to get a morning med, and this guy's blood pressure was, whatever it was, 100 over something, right? Where'd that go? We're just there. His last check was 101 over 50. Do we need to give a blood pressure medicine today? Do we hold today's dose and see what happens? Maybe he's going septic. He's got a fever. I don't know the new vitals. It's probably prudent to not give that medication yet in this acute setting. I'm not saying discontinue it and forget about it. I'm saying think about what is more likely to happen. They're more likely to go septic than they are hypertensive urgency in the next 24, 48 hours, right? So risk to benefit, monitoring your blood pressure and heart rate is very important every day or multiple times per day. And putting hold parameters is often the safest thing to do. So what are those hold parameters? Often it's a systolic less than 110 or less than 100. Somewhere in there is physician discretion. There's no, again, guideline that's going to tell you have to do something specific. But a lot of times we'll say if the systolic is less than 110, hold their medicine. Now, if you have a patient who has comorbidities of a cardiac history that you need certain medicines on board, then maybe that was a little bit different. But for this patient, he doesn't have heart failure, he doesn't have these other problems that, are also acutely unmanaged. He's a little bit more simple just with a basic hypertension. But if your patient were more complicated, you'd have to think if they were on 3 or 4 meds, which med do I want them to hold first and which med do I want them to keep getting for their other chronic problems? So again, thinking your heart failure patients there are some medicines that maybe don't want to hold as much as others, or some medicines that impact the blood pressure more than the others. So you would have to discern which medicine to hold first or to put hold parameters on. For this patient, it was a little bit more simple than that, but I did want to comment on this. So this patient right now is on what for his blood pressure? We scroll through the medicine list and we see that they just have the metoprolol, right, and lisinopril as their active drugs. So which one of these might, considering he's in a potential sepsis picture, you want to hold first?
Metoprolol.
So I heard metoprolol and Augusta. Why?
Because his reflex tachycardia can compensate if you take it away.
Excellent. So reflex, normally your body, when your blood pressure goes down, your heart rate goes up to compensate. If you're on a beta blocker, you can't do that. So actually the beta blocker would be something we put hold parameters on for a blood pressure and a heart rate for safety, as well as this discussion we're having now. But we want them to have that reflex tachycardia so that they can compensate a little bit. Some people will also say, well, lisinopril can cause renal dysfunction, so if you're going into an AKI, maybe you want to hold that drug. That's not an incorrect thing to think about, but in the acute setting, I'm more worried about the suppression of the reflex tachycardia personally. But some physicians may choose to hold both or to put hold parameters on both. That's perfectly fine. But making sure we're not continuing to give blood pressure medicine in people who are septic, that doesn't make any sense. I see it all the time. And again, if you're having a low blood pressure, maybe this patient does need some more fluids. What is their fluid status? We need to evaluate that. But don't, give fluids to correct hypotension while you're giving antihypertensives, because there's no real logic to that. So kind of think comprehensive. How do these problems interplay with each other? And the risk of one problem versus the benefit of treating this other problem. You can't look at a silo or one problem at a time. You have to think about how they interact, disease to drug, etc. Any questions on the hypertension issue? I know we're about to run out of time. Any questions about this patient in general, how we prioritized, or any of the specific interventions? I will create a document and kind of talk a little bit more about the dexamethasone problem, and I'll post that to ELC under this class shortly. If you have other questions, email me and I will upload the answers to those as well. Thank you all.